I'm going to pass the little sphere over to you. Okay, where's your name here? Okay, hang on. All right, so Felicity is going to be showing her desktop, and I'm going to be quiet, but what I would like to do is warmly welcome Felicity and Alison DInham and Sian Evans from London. They are at the Guy and St. Thomas NIH Foundation, that's their sponsor, as well as Lewisham and the Greenwich Trust, NHS Trust, and they are going to be speaking to us about physiotherapy, management and survivorship in head and neck cancer. So Felicity, it's all up to you now.
Okay, good afternoon if you're in the UK, good morning, good evening, wherever you are. Thank you very much to Jackie and the rest of the World Confederation of Physical Therapy team for inviting us to talk today. It was on the back of an article that was published in the Chartered Society of Physiotherapy magazine in the UK back in October on the physiotherapy pathway that we offer here at Guy's and St Thomas's. We're really interested to hear about other teams as well. We appreciate that the prevalence of head and neck cancer treatment options available do vary massively across the world. So if you've got any questions or things you'd like to share, we really do want to promote best practice, and we're open to questions at the end of the presentation. So just to put it into perspective, that is where we are at the minute in the big red box. We're currently in an office within the basement, and it's just to let you know how lucky we are to be working in central London. To the left there, that's the Shard, and you can see Tower Bridge at the background, and we're right next to London Bridge Station. I'm now going to pass you over to my colleague, Alison DInham, who is a static member of the head and neck team on the inpatient side, and Sian Evans, who works with me in the community head and neck team, as we look into the background of the team and the rest of our presentation.
Okay. So by way of introduction, we've been asked to talk about the physiotherapy pathway for head and neck cancer patients here in South East London, and first of all we'll describe a bit about our team. Then we'll talk about the background drivers which led to the creation of this pathway, including a bit about the cancer development strategies from the government, National Health Service and charity sectors. We'll look at the time points where physio intervention may take place along the patient's cancer journey and the interventions that may be performed at each of these, with a bit about the underpinning evidence base. The objectives are that on completion of this educational session, you'll have an understanding of the role of the physiotherapist throughout the head and neck cancer rehabilitation and survivorship pathway, and by having an awareness of the physiotherapy assessment and management of head and neck cancers from diagnosis through to either remission or to the shift to end-of-life care, we hope you'll be able to recognise common short and long-term consequences of head and neck cancer and its treatment, and have an awareness of the specialist needs of this patient population post-surgery or chemotherapy, radiotherapy, and how physiotherapy can have an impact. We aim that there will be enhanced understanding of the specifics of physiotherapy management in this patient group with regard to the respiratory, neuromusculoskeletal and functional consequences of head and neck cancer treatment, and an awareness of the evidence base for physiotherapy involvement in the head and neck oncology setting. Finally, that you have an opportunity to network and access peer support from other physiotherapists who have a specialist interest in head and neck cancer and cancer rehabilitation, hopefully coming away with ideas for implementation in your own physiotherapy practice. So to give some background, there are approximately 2 million all-cancer survivors in the UK today, 1.8 million in England, and this is growing, expected to be 4 million by 2030. Head and neck cancers combined as one group account for approximately 2 to 4% of all cancers in the UK, and it's the 16th most common cancer, with 8,358 new cases in the UK in 2013. This cancer rate is similar to the situation reported in Europe and worldwide. However, there are pockets over the world, especially in Southeast Asia, where head and neck cancer is much more common, though the actual rates are hard to determine, with head and neck cancer comprising somewhere between 6 and 30% of all the cancers reported. To give an idea of scale, about 42,000 diagnoses of head and neck cancer are made annually in the USA and approximately 14,000 in India. Head and neck cancers are grouped together due to their location in the body. However, they're not all the same type of cancer. The treatment and expected mortality can vary quite a bit from one type of head and neck cancer to another because of this. And the type of cancer is linked to the tissue type affected. For example, sarcomas arise in bone, adenocarcinomas from glandular tissue, and squamous cell carcinomas from epithelial tissue. And that said, over 70% of cancers in the head and neck cancer region here in the UK are SCCs. The site and staging of the cancer, for example, i.e. the TNM grading, are the most important factors in survival of cancer. And generally, mortality in this patient group is falling, with laryngeal cancer death rates down 33%. However, that's not the case for oropharyngeal cancers, where deaths are rising, nor for oral, thyroid, or salivary cancers, where mortality rates are all stagnant. Overall mortality of head and neck cancer in the UK is 13.4%, but again there's variation depending where you live and where your cancer has been treated in the UK. For example, oral cavity mortality can be anywhere from 2.9% to 21.7%. So imagine the impact of variation worldwide if it's just within the UK. Many head and neck cancers, if caught early, are potentially treatable, either with radiotherapy or alone, surgery, or with surgery and post-op radiotherapy, and there's an increasing role for chemotherapy to augment these treatments. But many of these cancers are not detected till they're well established, with 70% being advanced at diagnosis. With treatment, 5-year survival of head and neck cancer as a group is relatively good in comparison with the top 4 other cancer sites in the UK. So head and neck cancer 5-year survival is 50%, breast 79%, prostate 61%, lung 6%, and bowel 46%. The chances of recurrence are dependent on the original site of the cancer and the steps taken to address the risk factors for developing cancer in the first place. Most recurrences happen in the first 1.5 years following treatment, and overall 50% will get a recurrence within 2 years. Between 9 and 23% will develop a second primary cancer within 20 years, with patients with oral cancer tending to get second primaries in their head and neck, whereas laryngeal cancer patients tend to get second primaries in their lungs. So that's a bit of background to head and neck cancer in the UK. Physiotherapy-wise, head and neck cancer patients are a small but needy group requiring intensive support care from many members of the multidisciplinary team, particularly allied health professionals such as speech therapists, dietitians, and physio and occupational therapists. The pathways for allied health professional routine input remain quite variable across the UK, and referrals can be patchy depending on how well patient needs have been identified and assessed, and depending on local knowledge regarding the potential role and scope for rehab, i.e. what these professions actually do. Generally, the impression is that physiotherapy to the head and neck population is currently provided on a reactive basis to reported symptoms. But in the past, not all areas have been routinely screening thoroughly for all potential symptoms in this patient group. And many people live with potentially reversible symptoms as they don't know that these symptoms could be improved in the context of having and surviving a cancer diagnosis. In the UK, physiotherapy to this patient group may be provided by a range of different specialty physios. In some areas, they'll be seen by acute, post-op respiratory or plastic surgery physios. In others, general oncological rehab physios, and in others, they may receive input from the musculoskeletal outpatient physios. But pathways are rarely joined up or specific to this complex head and neck patient group. So work was undertaken to develop a dedicated head and neck physio team here in South East London, aiming to provide a seamless care pathway from diagnosis through treatment and on into survivorship. So here at Guy's, part of the Guy's and St Thomas's Foundation Trust, or GSTFT, we currently have dedicated head and neck specific physiotherapy staff based in a regional specialist centre for head and neck cancer diagnosis and treatment. There's a routine pathway for patients undergoing head and neck cancer surgery, and the rest of the multidisciplinary team can also refer any patient, be they surgical or undergoing chemotherapy or radiotherapy for head and neck cancer. And they can refer at any time point should physio-amenable problems occur. Our inpatient physio team sees people preoperatively, post-operatively, and for respiratory care and or rehabilitation as required in their oncology rather than their surgical setting. Our outpatient physios see people in one-to-one sessions or in groups, such as our general oncology rehab exercise group. Our hospital-based team is extended out into the community with our community head and neck team, also known as CHART. And this is a groundbreaking development at the time for cancer support services. It's now been operational for 5 years and covers 6 London boroughs. Referrals to the CHART team come from Guy's, but also from other regional hospitals and further afield. And on the team, there are speech therapists, dietitians, clinical nurse specialists and physios. Patients have key workers within the team. A particular role for the physio on the CHART team is airway support for those going home with a new laryngectomy or tracheostomy, and to commence and progress tracheostomy weaning, and in these cases the physio is generally the key worker. The team provides care in a closer-to-home model, with specialist one-to-one appointments, but held in community clinics closer to the patient's home, or home visits should these be indicated. They've just been recommissioned as ongoing, which is great news, as it secures the team's future instead of having to reapply for funding every 4 years. The aim is to provide a seamless pathway of care from one team to the next. And apologies if you can hear the drilling going on outside the room. To put it into perspective for you as to where we're based, this is London divided into boroughs. So Greater London has approximately 21 million people, and there are about 1.6 million people in the 6 boroughs of South East London, highlighted by the pink colour. The Oxford Cancer Intelligence Network report from 2002 to 2006 says that about 5,000 people with head and neck cancer in London, and 1,022 of those are in South East London, which is about 200 people per year in our area. So the pink area on the map is the area covered by the CHART team, and the main catchment area for Guy's as a regional specialist centre, which is represented by the dark blue dot in that green square. The pale blue dots are the district general hospitals where head and neck cancer diagnostics and care may have taken place in the past, and these DGHs now have a modified role, more suited to their facilities, staffing and the volumes of patients they see, in providing the support and ongoing care for these patients once their specialist needs have been dealt with at the regional specialist centre. It was felt best to centralise care in the regional specialist centre via a hub and spoke model, but with the hub in central London rather than the centre of the area, due to access to facilities and transport links. So next, we will briefly review some of the cancer developments which acted as drivers to the creation of our team. In the late 1990s, the government at the time produced a report about cancer care, and they said at best, cancer care in this country leads the world, citing medical research, breast screening programmes, children's cancer and palliative care services as examples, large areas developed by charities. However, crucially, it was identified that survival rates for many of the major cancers in the UK lagged behind the rest of Europe. And inequalities were identified, with not only the poor being far more likely to get cancer than the rich, but also their chances of survival were lower too. For example, deaths from lung cancer were 5 times higher in male unskilled workers than in professionals. There were too many variations in the quality of care and in treatment across the country, leaving cancer patients frustrated by a postcode lottery, meaning you could be a winner or a loser in health because of where you lived in our country. The NHS Cancer Plan for England of 2000 aims to provide a comprehensive strategy for bringing together the prevention, screening, diagnosis, treatment and care for cancer into a full pathway, and also provide the investment needed to deliver these services in terms of improved staffing, equipment, drugs, treatment and information systems, and 10-year targets for survival improvements were set. In 2004, the specific recommendations relating to head and neck cancer were published by NICE, the National Institute for Clinical Excellence. These are the Improving Outcomes Guidelines for Head and Neck Cancers, or the IOG. And in January 2005, the South East London Cancer Network Head and Neck Tumour Working Group, containing representatives from 3 major hospitals in the area, held a multidisciplinary workshop to discuss and agree the implications of this IOG, and they considered the ideal patient pathway for diagnosis, treatment and follow-up, and discussed arrangements for the support services required from the point of diagnosis onwards. And They identified key points for when rehabilitation would be appropriate to be offered. When this mapping process was complete, it ended up being that rehab was felt to be appropriate at each stage of the pathway. And as a result of the recommendations of the IOG, all cancer care was to be provided at Guy's as a regional specialist centre. And a single coordinated specialist local support team should be established to provide long-term support in the community, and therefore that was the work on the development of the community head and neck team when it began, and business cases were started to establish the extra posts and facilities required. Further developments were made as a result of the developing survivorship agenda.
The survivorship agenda has incorporated the key cancer rehabilitation stages stated in the Dietz model 1980, and these are preventative, restorative, supportive and palliative. And during each stage of rehabilitation, the physical, mental, emotional, social, sexual and economic needs of the patient must be considered. AHPs help cancer patients not only recover from the physical changes that accompany their illness or as a result of cancer treatment, but also function in everyday activities and reach their goals in physical health. However, the concept of rehabilitation in cancer requires a much better understanding by the workforce, commissioners, service planners and people with cancer, as it can fundamentally improve the life of the person if their needs are identified and met. But by addressing the provision of cancer rehabilitation, cost savings are made, and cancer care pathways do not always explicitly reflect cancer rehab as part of the process. In 2007 to date, many key national initiatives that have directed survivorship and rehabilitation goals have formed, and they have shaped services in London in particular. They have helped orientate the NHS, public health and social care services towards delivering the improvements and outcomes which matter to cancer patients, and we've provided them here for you to go back to. They have been used in directing our physiotherapy specific aims. And so what are these aims of physio within the survivorship agenda? Well, survivorship focuses on the health and life of a person with cancer from diagnosis through towards the end of life. And these include issues related to the ability to access healthcare and follow-up treatment, manage the late effects of treatment, monitor for secondary cancers, empower patients to play an active role in decision-making, increase quality of life and survival, and improve access to high-quality information tailored to an individual's needs. Family members, friends and caregivers are also considered to be part of the survivorship experience. And for physiotherapy specific, our aims are to manage consequences, symptoms and impairments of head and neck cancer treatments, improve physical and psychological performance to reduce activity limitations, increase and improve quality of life to reduce restriction on participation, health promotion, and this includes pre-rehabilitation, during and post, including oncology rehab classes, education of both patients and our colleagues and other services of treatment and diagnosis, promote self-management through use of survivorship groups, wellness days, exercise and diet, work to reduce risk of recurrence, and return to work, functional and vocational rehabilitation. A strong aim is increasing patient participation in physical activity throughout the treatment and rehabilitation. And so what is the evidence behind this? The role of exercise is well established in breast, colon and prostate cancer patients. They found that they can reduce their risk of dying from the disease by 30 to 40% if they do recommended levels of activity. This is due to the effects on comorbidities, primary cancer and cancer recurrence. Within head and neck specific, the study of physical activity and quality of life in head and neck cancer survivors concluded that few head and neck cancer survivors are participating in any moderate or vigorous exercise, and over half are completely sedentary. It is estimated that 1.6 million of the 2 million current cancer survivors are meeting the standards to benefit their health. But according to Balance et al. In 2005, despite the strong evidence base for exercise alleviating and managing cancer-related side effects, exercise is not being delivered as part of an ongoing consistent lifestyle change. Patients' individual pathway will vary depending on many factors inside and outside of acute medicine. Exposures to exercise will vary massively. And so before we look at our physiotherapy interventions and surgery in more detail, we do need to consider some of the challenges met in the development of our pathway. One of these will be the perception of the role of physiotherapy within the head and neck multidisciplinary team. physiotherapy is not specifically mentioned in the IOG for head and neck as a core member of the head and neck multidisciplinary team, but it is included as a wider rehab supportive care in cancer in general. The 2011 ENT UK Head and Neck Cancer MD Multidisciplinary Management Guidelines do state physio as a member of the MDT and refer to the National Cancer Action Team Rehab Guidelines. There is a developing rather than established evidence base for physiotherapy within head and neck. And luckily all the other developments ongoing in cancer care have helped support proposed developments at guides and symptoms with the physio role. And the second challenge is ensuring the continuity of care. Clinicians need to require the same training and manager structure in place. And our community team, the CHANT team, is viewed as an extension to us rather than a separate team. And communication is vital. We have a great pathway between the physiotherapy teams across the two services to communicate well, and the community team come into the hospital to attend planning meetings, handovers and treatment planning.
So, to review our input across the patient pathway, we'll look at physiotherapy input at each stage. So our patients are seen pre-treatment in an MDT assessment clinic. Physio currently only see the major surgical candidates, so if they're missed, we do try to see them on the ward preoperatively. At this clinic, the patient's history is confirmed with extra detail about the sorts of information of interest to the allied health professionals. We discuss general advice for recovery and return or commencing physical activity. We also inform the patients about post-op potential complications and discuss their expectations of their rehab post-operatively, prepare for tracheostomy and weaning, and give preoperative advice as indicated, for example, pain management, smoking cessation, nutrition or swallow advice, and exercise. So it's an opportunity for information gathering to aid rehab motivators, goal setting and discharge planning, but also information giving regarding expected post-op course, the expectations of rehab, and treatment therapy. So what do head and neck operations consist of? The first part of the operation is the resection of the primary tumour site, for example, maxillectomy, mandibulectomy, glossectomy, laryngectomy, pharyngectomy, or thyroidectomy. Sometimes access to perform the resection requires extensive incisions, for example, lip and jaw splitting. The resection is often accompanied by neck dissection, which is the removal of lymph nodes in the neck, and there are clear patterns for spread to various levels within the neck. These diagrams show where the different theoretical neck levels are situated. Anterior oral cavity cancers tend to spread to levels 1 to 3. Pharyngeal and laryngeal cancers tend to spread to levels 2 to 4. The most common level for local nodal spread is level 2. Contralateral metastases are uncommon in anterior cancers, but substantial in cancers of the base of tongue, soft palate, and supraglottic larynx. The types of neck dissection. So to access these lymph nodes, the skin and subcutaneous fat tissue is raised and folded back. The fascia, fat, lymph node-bearing tissue is meticulously elevated off, and tissue is removed as one large mass, its arrangement marked to aid histological interpretation. Other structures are dissected and may be removed, chiefly the sternocleidomastoid muscle, the internal jugular vein, and the spinal accessory nerve. In a selective neck dissection, all of these structures are preserved. In a modified radical neck dissection, one or more of the structures is preserved. Radical, they're all removed, so that's spinal accessory nerve, sternocleidomastoid, and internal jugular vein are sacrificed. And in an extended radical neck dissection, additional things may be removed. And the extent of the neck dissection is important, as removal of the spinal accessory nerve can lead to reduced innervation to upper traps and resultant low tone around the scapula. This can alter the position of the scapula at rest, leading to protraction and depression of the shoulder girdle, with a winging scapula evident of reduced proximal shoulder control. It can result in shoulder weakness and impingement during flexion and abduction, especially on the biceps tendon, causing a painful arc. It's well known that neck and shoulder dysfunction can be present post-neck dissection surgery, regardless of whether the spinal accessory nerve has been spared or not. So despite selective neck dissection procedures generally being reported to have less spinal accessory nerve dysfunction than radical neck dissections, still 50% of patients with no spinal accessory nerve dysfunction still report shoulder problems such as pain. And our neck dissection only population with no flap reconstruction demonstrated in 2012 that 90% had reduced neck range at hospital discharge and 64% had reduced shoulder range. And we're currently doing work to establish whether this range deficit is linked to functional problems. Following the removal of tissue bulk, reconstruction is required, and often autograft flaps are used to repair the defect left after resection and provide bulk, for example vessel coverage after an extensive neck dissection. The artery and veins supplying the flap of tissue are anastomosed to recipient vessels at the reconstruction site, and the flap can be osteomyocutaneous, i.e. bone, muscle and skin, myocutaneous, so muscle and skin, or cutaneous, just skin. Pedicle flaps need a natural blood supply of the tissue attached at one end. Free flaps may be required due to the distance needed to relocate the tissue. The area where the flap was taken from then needs to be covered with a skin graft. These can be split thickness or full thickness. With split thickness skin grafts, the donor sites can heal spontaneously with little scarring. However, the graft itself can shrink or contract. However, in full thickness skin grafts, there's little tendency to contract, but the donor site can't heal spontaneously. They have to be closed by direct sutures, which limits the size of the graft.
So, having seen some of those gory pictures, you can begin to appreciate some of the post-op complications that our head and neck population suffer. So, these can vary from general lengthy general anaesthesia problems right the way through to head and neck specific. Some of the head and neck specific complications that I mention now I will discuss in a little bit more detail. So, firstly, patients will suffer with some respiratory complications. These could be atelectasis, reduced lung volumes, a VQ mismatch, retained secretions, impaired cough strength or altered dynamics to their cough, or they may come back from theatre with a tracheostomy, in which case physiotherapists are heavily involved in MDT decision making regarding tracheostomy care and weaning plans. It's been found that patients post head and neck surgery suffer with 7 to 44% do suffer with post-op pulmonary complications. Other complications could be a chyle leak, which is seen in the top right-hand corner, a milky protein substance if the vessel is nicked, a seroma, a hematoma, infection, necrosis or wound healing issues, both at the primary surgical site or the flap donor site, clotted bleeds, these could be traumatic or due to invasion from the tumour later down the line, neural damage, whether the nerve has just been pulled and stretched and bruised, or whether there's been micro tears or indeed sacrifice of the nerve, internal jugular vein excision, which will cause acute post-operative swelling to the head and neck. Normally, when there's unilateral damage to the internal jugular vein, collateral, contralateral and retropharyngeal vessels tend to compensate. If they've had bilateral internal jugular vein excision, they tend to have significant venous post-op edema and chronic lymphedema further down the line. Lymphedema is another problem. Postural changes, these may be short-term or long-term, associated with attachment, fear avoidance, scar healing. Shoulder pain and dysfunction. Pain, both acute and chronic. Chronic pain is thought to increase, and if we're thinking about our head and neck population, risk factors are previous radiotherapy, previous surgery, previous chemotherapy, preoperative pain, repeated surgery, or anxiety and depression, all of which are problems with our head and neck population. Reduced flap donor site range of movement, scarring, keloid scarring, cording, sensitivity or hypersensitivity in the area, a dry mouth, fatigue, global deconditioning, and psychological implications related to identity, body image, and expression after theatre. So, early physiotherapy management. For patients undergoing major reconstruction, they tend to be transferred to our intensive care unit, where they'd be seen by our intensive care respiratory physiotherapists. There, they'd have a respiratory assessment and early treatment, including mobilisation. They'd be taught thoracic expansion techniques if they're not upper mobile. If they are upper mobile, we get them sat out in the chair and have them walking the length of the ward within the first couple of days. In addition to this, we add physical activity promotion, such as bike exercises, walking up and down the stairs, sit-stands at the bedside, in order to avoid some general post-op complications, such as DVTs, fatigue, global deconditioning, and maintenance during their inpatient stay, to improve psychological well-being. Psychological engagement with physical activity has thought to reduce global deconditioning, and in turn reduce length of stay and the risk of hospital-acquired infection. Acute pain, this is associated with posture, support of the limb where the surgical site is. Physiotherapists can help by supporting the limb, relaxation techniques, ensuring that we're using as and when pain relief 20 minutes before treatment, for example. Lots of reassurance, and empowering the patient that despite the fact they have lines and drains, they can still get up to the toilet and walk the length of the ward. Initially, we wouldn't move the surgical site until the drains were removed, because we're at risk of dislodging the exact location that drain has been sited. Once the drains have been removed, we progress to simple range of movement active exercises of the neck, shoulder, flap donor site, and temporomandibular joint. For post-operative edema, again, we prescribe exercises, facial exercises, for example. And for facial weakness, we offer early management to prevent long-term consequences. Other early physiotherapy considerations would be the fact that actually our patients are malnourished, might have a low BMI, might be cachectic, and have a low muscle mass even before they had a lengthy 16-hour operation. Global deconditioning and reduced exercise tolerance, this might be related to their diagnosis initially or their lengthy hospital stay. Comorbidities, which we would establish hopefully preoperatively during their pre-treat assessment appointment, and these might impact on their mobility or goals that we set. It's worth mentioning here that there's a varying degree of diagnosis and undiagnosed COPD in the head and neck cancer population, which can be up to 30% of the population. And finally, breathlessness management, especially with those altered airways, where they won't have to be able to utilise the same mechanisms to manage their breathlessness. So, before discharge from hospital, we need to look at their functional deficit. For example, have they had a lower limb flap donor site, in which case they might need a walking aid, or need to practice the stairs, or need to be referred to occupational therapy for equipment. Social support. Have they got family or carers at home? Do they need a new package of care to support them, whether this with tracheostomy care, nasogastric tube feeding, or with their exercise prescription? We then organise onward referrals. This might be head and neck specific, in which case to our outpatient or community physio teams, or more general with the re-enablement community physiotherapy teams and smoking cessation. We'd also consider at this stage whether we needed to get in touch with the community head and neck team to organise an airway visit. We aim to get these completed within 24 hours of discharge from the ward in order to check that equipment, so suction, nebulizer boxes are up and running, to make sure that they've got the right medication, and to make sure that they have got access to emergency services. This might be through the text emergency service that we have with the London ambulance. So, they've now been discharged into an outpatient or home setting, in which case we continue all of the above. I'm now going to talk about these in a little bit more detail. Before prescribing any exercise program, it's good to revise the stages of wound healing. Here is a photograph of a male patient of ours, 2 to 3 months post-operatively. He's 28 years old and really took on board a good skincare regime post-op. If we go through the stages of wound healing, the inflammatory stage is where the vascular responses and cellular responses are seen, so we'd only encourage normal movement. 1 to 10 days post-operatively, we're starting to restore mechanical integrity to the wound, so the scar might appear red and raised. Tensile strength of the wound is not back to normal, and there's a poor response to mechanical stress. In stage 3, we have increased collagen deposition. Firstly, these will be weak fibrils. Later, the later stronger, flexible collagen fibers would be laid down. Rapid increase of the tensile strength occurs during this phase. Finally, at stage 4, we have remodeling of the scar. The collagen becomes dense and less susceptible to collagenase, which is the enzyme that breaks collagen down. The scar becomes paler and flatter, and we are able to start exercises, especially resistance work, as they respond to tension, pressure, and manual work. There's several benefits been found to movement and exercise for scars and scar tissue recovery. Firstly, it might improve the cosmetic appearance and aesthetics of the scar. Increased blood flow will come to the area, which will normalise vascular regeneration in the area. And finally, we can work to reduce formation of excessive crosslinks and adhesions. We promote scar management as soon as the scar has cleaned, dry, and all the scabbing has fallen off. This tends to be 4 to 6 weeks post-operatively. We encourage the patient to massage the scar a couple of times a day for 90 to 120 seconds at least, to work the scar from a gel to a solid state, and to be as firm as possible in order to reduce adhesions in the area. Then we progress our neck and shoulder rehabilitation. So, looking back at the picture you saw of the spinal accessory nerve damage with the ringing shoulder, the protracted and depressed position at rest, we start with lots of scapular retraction and control work. We then move on to restore neck range of movement. For the first few weeks, this would just be active range of movement work, maintaining the stretch. After 4 to 6 weeks, I then progress to a passive end range hold. For shoulder range of movement work, if they're particularly struggling, I'd go right back to basics, so starting with supine or active assisted or pendular work. This can be progressed to active work, and then we'd start strengthening about 4 to 6 weeks post-operatively. Even though there may not be sign of spinal accessory nerve recovery and upper traps activity at this stage, we'd still continue to strengthen the general shoulder girdle and rotator cuff, either with free weights or TheraBand exercises, with isometric and concentric strengthening. Alongside this, we then start to rehab the flap donor sites. So, for example, if you had a fibular flap at the lower limb, we'd start with ankle active range of movement exercises and then work with weight bearing and loading strengthening work. And throughout this, the patient needs to be aware of posture and postural re-education. More specifically, looking at the temporomandibular joint, if you think about your major reconstructive surgery, the temporomandibular joint is often involved. With surgical scarring, so the primary site, but also during radiotherapy you can get fibrosis of the soft tissues around the temporomandibular joint, which leads to trismus. Day 1 post-operatively, we'd assess jaw range. As a very gross measurement, we'd need to make sure that they've got 3 fingers opening, as demonstrated in the diagram. We'd start with active stretching exercises and progress to active assisted and passive end of range hold exercises and lateral glides of the temporomandibular joint. After 4 to 6 weeks, if they have got intraoral scarring, I would teach them intraoral scar massage. If I think that a patient's jaw range is particularly at risk during radiotherapy, or indeed after surgery, they have less than 2 fingers range, we will refer to the consultant surgeon for permission to use the TheraBite, which is seen in the diagram in the bottom right. The TheraBite itself is thought to have increased opening by 5.4 millimetres on average. However, the odds of achieving mouth opening more than 5 millimetres does reduce as time from oncology treatment increases, which emphasises the need to really get on board with temporomandibular joint stretches post-operatively. We do receive referrals for temporomandibular joint exercises for those that haven't had surgery, so they may well just have chemo, radiotherapy, and then develop trismus. And we're currently discussing whether there's a need for prophylactic exercise prescription before they've even had treatment. Facial weakness is a common problem post-surgery, particularly with carotidectomy surgery or anything that involves swelling over the side of the face where the facial nerve might sit. The most important factors to consider with early management of facial weakness are listed below, and their aims are to reduce the likelihood of long-term problems and to promote good conditions for nerve recovery rather than increasing nerve recovery itself. So first of all, we'd aim for symmetry at rest. Patients might use a mirror to guide them. We'd aim for normal eating and drinking, so encouraging patients not to eat all their food by chewing on one side of their mouth. Eye care is particularly important if you've got ptosis or inability to close the eye. So taping at night and using lubricants and eye drops and passive blinking during the day are extremely important. Mouth care to avoid biting of the fragile intraoral tissue, and using mouthwash to remove debris after eating if they're unaware due to sensory loss. And then the three pictures on the bottom there indicate massage, stretches and exercises for management that we prescribe. So the massage aims to help increase the awareness of facial movement and the sense of movement on the affected side, so where those muscles should be moving. Stretches are for the unaffected side to make sure that they don't become shortened and tight. And gentle exercises on the affected side are to help prevent muscle wasting, and there's a little bit of evidence to show that exercising the area will increase blood flow, and with increased blood flow you may have increased nerve recovery. More recently, physiotherapists within our team have started to take on board management of mild to moderate head and neck lymphedema cases. Our lymphedema service at Guy's and St Thomas's noticed a rapid increase in the referrals they were receiving to head and neck patients from 10 to 33% in 2 years. So we decided that with the neck exercises we're doing already, we could complement their service by issuing a Hereford collar, which is seen on the top there. The Hereford collar is full of tiny little beads, and when worn quite tightly around the neck can add external compression, and in line with the exercises that then add internal compression with muscular contraction, it's thought that we're able to promote drainage of the head and neck lymphedema down towards the axilla. Other things that physiotherapists can do there are other compression garments available, but very tricky to wear around the head and neck. We need to promote excellent skin care in the area. Where the lymph nodes may have been removed, we're at more risk of local infection because lymph nodes are known to secrete lymphocytes. So we need to keep the area nice and moisturised, make sure that we're keeping the area out of the sun to avoid dry and breaking of the skin. And finally, secretions and dry mouth. So we have three main pairs of salivary glands within the mouth. Number one being the parotid, number two, submandibular, and number three, the sublingual glands. Although the parotid gland shown there on the far right is the largest of the glands, it doesn't secrete the most saliva. Our saliva is made up of a mixture of serous and mucus liquid, and depending on which glands have been affected, either with radiotherapy or surgery, patients have huge problems with a dry mouth post-operatively. Normally, we produce 0.75 to a litre of saliva a day, and it's responsible for lubrication and contains digestive enzymes for breaking down food. Radiotherapy will affect the saliva composition, creates less of it, leaving patients with very sore, dry mouths. They're then prone to infection and have difficulty with speaking and swallowing. They're then at risk of getting mucositis, so inflammation of the goblet cells that secrete mucus, halitosis, bad breath, nausea, reduced appetite, and even as far as tooth loss. Pharmacological management has variable effectiveness. From a physio point of view, we encourage regular saline nebs. Although they may not have secretions from a respiratory infection, so a lower respiratory tract infection on the lungs, saline nebs can improve viscosity of saliva and secretions within the mouth so that they're able to cough and clear it into tissues rather than pooling in the oropharynx. Mouthwashes are very handy, and there's many available. Some patients find some more important than others. In extreme cases, tweezers and deep Yanker suction or oral sponges might need to be used. Tweezers and Yanker particularly with laryngectomy patients where they're already at risk of dry and viscous secretions because of their loss of normal humidification mechanisms. And finally, from a physio point of view, we can offer cough augmentation strategies. So we do utilise cough expiratory flow assessment, breath stacking techniques, forward leans and manual assisted coughs to assist secretion clearance. Carbocystine is an anti-mucolytic that we would make sure that's prescribed in the community if there are any risk of retained secretions. And there's a small amount of evidence that acupuncture can reduce dry mouth within the local area to reduce the symptoms of xerostomia. Finally, it's important to recognise that there are precautions and contraindications to physiotherapy management, and here's a brief list. Acupuncture can be known to cause wound infection at the site, especially if you've had a neck dissection, but can be used on contralateral limbs. Manual therapy we need to be cautious of, especially patients going under radiotherapy where their skin would be painful to light touch and often broken down. Stretching, so care needs to be taken, especially with wound healing and blood counts and risk of hemorrhage. Exercise, making sure that we're giving appropriate intensity of exercise and recognising patients' blood counts during that time, so whether it's haemoglobin or white cell count. Electrotherapy. We don't want to be delivering electrotherapy on areas that are sensitive and fragile post-radiotherapy. Avoiding exercise if the patient has had IV chemotherapy that day or within 24 hours. Blood counts as a guide here at Guy's and St Thomas's, we wouldn't exercise anybody with platelets less than 20, a haemoglobin less than 8, or a white blood cell count less than 3. If there's an active seroma, so a pocket of serous fluid under the tissue, we'd cut down the exercise specifically in that area. Bone disease, we need to be cautious of impact, intensity and resistant exercise due to risk of pathological fractures. And be cautious of osteoradionecrosis. The X-ray there on the right demonstrates osteoradionecrosis and normally happens within the mandible bone. So in terms of physiotherapy, I'd be cautious there with temporomandibular joint exercises and passive end of range holds. Finally, from a general oncological point of view, be aware of red flags, so motor, sensory and bladder and bowel disturbances, sleep that's grossly disturbed by pain, or referred multisegmental band-like pain. Here is a summary, really, of the routine physiotherapy pathway here at Guy's and St Thomas's, and summarises everything I've just said and where and when we might initiate the different stages of rehabilitation.
So some late physiotherapy considerations that we also look at. Physiotherapy intervention often covers a lengthy time frame, and some consequences of cancer treatment does arise much later on down the line. And it's quite important at this stage that it's vital to continue with long-term support for our patients and helping them to embed self-management
with these patients and doing some more education. Within the physiotherapy role, we do use the holistic needs assessment to complete with the patient, and this really assesses what the ongoing patient needs are to ensure that we're meeting their needs and that we're not missing out on anything that the patient might find more important with them. Examples of this can be around sort of cancer-related fatigue, where we can get involved with patients and throwing them onto oncology rehab classes, continuing with specific strengthening around maybe specific tasks that the patient would like to be part of, and providing ongoing referrals to these patients to ensure that maybe their psychological support or issues around image and identity are dealt with and the patient's not having to continue living with it. For patients, unfortunately, some do get recurrence of disease or have ongoing active or advanced disease, and even at this stage we will be looking at the consequences of the further management of recurrence of patients, and this will include again surgery, maybe chemoradiotherapy, potential palliation of the patients with treatment, or actually sometimes the patients decide to not go for any treatment at all. And we have to manage the side effects of these treatments and the consequences, and continuing with understanding that patients' goals at these stages might actually change, and their focus might be a bit different in light of their new diagnosis. But we will continue with their rehabilitation and getting other specialist services involved with their care. Patients may not be cured but can live for longer periods, and we have to ensure that we maintain their quality of life and maximise the quality of their survival. Physiotherapies are required to adapt rehab according to the patient need and consequences at this stage, and we continue to work with their goals and making sure that they're achievable, and also providing some psychological support at this time. We do continue to work with patients through their palliative stages or end-of-life care, and this is particularly joint working with the specialist palliative care teams within the community and also in the hospital. We ensure that patient-centred goals are still something to work with and ensures we are meeting the patient's needs and again ensuring their quality of life. And it's important at this stage to avoid patients feeling like we have given up on them and their families, and that we continue to work. The Coordinate My Care programme has been developed within London to give people with chronic health conditions and or life-limiting illnesses an opportunity to create a personalised care plan in order that they might express their wishes and preferences for how and where they are treated and cared for. This care plan is shared electronically with all providers of urgent care, especially in an emergency situation, and these may include ambulance staff, GPs, out-of-hours services, hospitals, nursing and care home, hospices and community nursing teams. And for those patients that do remain well and have long-term management, we continue to support patients at this stage and ongoing if indicated and have the needs. And we do support patients in adapting to a new functioning, enabling their quality of life, the provision of strategies or equipment to continue with their independence. Particularly patients if they've got fatigue, we work closely with dietitians and looking at the patient's lifestyle, exercise and health. We provide support and ongoing referrals for patients with any psychological needs around maybe fear of recurrence. And we also are continuing to reassess the patient using patient-recorded outcome measures, and these can be, for example, the functional assessment of cancer therapy, quality of life questionnaire, and also the holistic needs assessment as mentioned before. We do make a lot of onward referrals out to other community services that are out there for patients, not just related around cancer. There's the GP referral schemes, which are referral schemes into providing physical activity in a supported environment within local gyms for the patients. There are specific shoulder exercise groups available within the hospitals. Guides and symptomists have their own oncology rehabilitation class that patients have access to. And local hospitals also have some rehab schemes in place. We also really aim to help patients return to work if they've, particularly those patients that are manual workers. We have quite key roles around rehabilitating these patients back into their jobs. How they get to work in London as well. is quite key. Often they have to get onto trains, walk a distance, onto tubes, and sometimes in the stage of rehab they can't even walk down the street. And we also can provide support around ensuring that work is adapting for them and able to get back into their roles. Restoring family position can be quite important, and particularly for men who sometimes feel that the effects and consequences of treatment can be quite emasculating for them, such as weight loss, loss of muscle mass. And we do support patients in getting back into activities and hobbies, and there's quite a lot of community support out there that we have direct access into. So these are just some quotes from our patients that have come up through some of the treatment that we've provided for them. And moving forward, what future developments do we have as a team within our pathway, and what are we looking at to improve it? Well, we are looking at during the diagnosis side of patients' care, promoting healthy lifestyle, and including smoking cessation, diet and physical activity, which is also already part of some of the pathway. We are looking at becoming more prominent in the chemoradiotherapy patients' pathway, to include more routine range of movement exercise and again physical activity interventions at this point. And also increasing our links to and confidence to access ongoing exercise opportunities for our patients. And future projects that we do have as a team are working towards specific shoulder exercise classes for patients with neck dissections, wellness groups that may be more specialised towards neck dissection patients, developing and working relationships with our musculoskeletal communities out there as part of an education role to ensure that patients are getting good access to care. Patient-reported outcome measures at different pathway points, and of course we've got our brand new cancer centre being built at Guide at this current time. And really the key message is that physiotherapy intervention is quite crucial in the patient's journey before and after the neck dissection, and ensuring that we work within the survivorship agenda and vitally ensure improvements in patients' quality of life. And this is just a brief take-home message for us all with regards to physios working in head and neck cancer.
If any of you would like to contact us in the future, we've popped our email addresses on there and our postal address, and we'd like to welcome any questions.
This is Jackie Druin. Oh, go ahead, please go ahead.
Hello?
Oh, you can ask your question now.
Jackie, will we expect any questions via the microphone?
Hello? Hello?
Hello?
I don't know if people heard me. This is Jackie Druin. I might have had my microphone muted, but there's two ways that you can communicate with our speakers, and one is you can unmute your microphone and speak directly to Felicity, Alison, or Sean, or if you click on the top, there's a chat line that you can type something into on the chat line. So I will mute my microphone and let other people have an opportunity to speak.
Hello. Hello.
Hello?
Hello, can you hear me?
We can now, yes.
Hello.
Yeah, we can hear you now.
Can you hear us? Hello?
If anyone has any questions, I do notice on the chat line, Fiona Campbell sent that she works at a hospice in Birmingham and she's learned a lot through your presentation and she wanted to thank you very much. Stanley, says he's having technical problems, so he can't ask his question, but Stanley, you certainly can type it in. So if people have questions, they can either use their microphone or you can type.
Alternatively, Jackie, if you want to contact us via our emails, they're more than welcome to.
Yes, that's a great idea too. So if you come up with a question
yeah,
later
the chat
on,
line seems to be working. We've had contact from somebody saying thank you for the
you're
good.
welcome to contact the team.
Oh.
I apologize. This is the best technology right now for this, and we're going to try and go ahead with Nina Chegbo, who's our education director, to identify some better technology. But I think at least we're starting. I was so pleased with this presentation because you talked about all of the issues that you went through over the years to develop it. So this gives people an idea as far as developing the program.
Jackie?
You also talked about methods.
Jackie, was that a question for us?
No, I just was congratulating you and saying what a great presentation it was. Is there somebody else trying to ask a question? If you could talk a little louder. There's a comment on the chat line that Fiona is asking about the notes, and what we can do is we can send a PDF form of the PowerPoint from Felicity. Oh, there's our team, and Sean and Allison. So if they could provide me with a PDF, then our secretary Ann can the presentation with the contact numbers to people that are listening to this. We also will be recording this, or we are recording this right now, so if anyone wants to watch it again, we will be sending out a different link to the recording. The recording will also be available on the WCPT IPT-HOPE website, probably within a couple of days. It takes a little time for it to turn into a recording. So any final comments, Felicity or Allison?
No, I don't think so. We've spoken enough.
But if anybody has anything they want to share about their practice, we'd be keen to hear as well.
Okay, great. Well, I thank you so much, and I just wanted to make the comment that we will be awarding you the International Scholar Award from the IPT-HOPE division. It will be signed by Nina Chegbo and Ann Newsom, who are Secretary and Educational Director. And I can't thank you enough. This is one of the best presentations we've had in terms of organization and science and application and how to do this, how to get this going, as well as how much work it takes. And then I especially appreciated your comments on what are some of the contraindications or precautions you need to do, because this is something I've seen so much in practice, is that we can use our physiotherapy skills, but there's a whole new set of patients and comorbidities and issues we have to be well aware of in working with these patients. And so I just want to kindly thank you once again. And if there are no further questions, we'll be signing off. And From Michigan in the USA, I'm saying good afternoon. I think in London, what do you say there now? Is it good evening?
Good evening.
Good evening.
Wonderful presentation. Thank you again.
Thank you.
Thank you, Jackie. Bye.
My pleasure. Goodbye.
Bye-bye. Oh, right, so we've had a John, Mark, I wouldn't send them out. I would say PDF our presentation. No, it's going to be available on the website. The recording should be available on the website, but you can use them on a different computer at some point.